In this lecture, we will cover evaluation of clinical information systems. As can be seen in the core content outline, this topic is covered in item 3.5.6. Drilling further into the outline, we see that clinical information system evaluation consists of outcomes relevant to the clinical goals and quality measures, qualitative and quantitative methods for evaluating clinical information systems, and evaluation plan design. The key topics we'll cover in this lecture are the measurement of usage, outcomes, and cost of clinical information systems, quantitative research methods, qualitative research methods, and actionable evaluation research in operational settings. As an overview then, we'll cover clinical information system evaluation goals and measures and quantitative and qualitative evaluation methods. Let's first focus on evaluation goals and measures. We'll look at usage, that is the proportion of users who use a system that's made available to them, outcomes, the measures of various clinical, operational, and other outcomes, and costs, both costs of systems and their cost benefit. Let's first look at usage studies, and there have been studies carried out in a variety of different settings. These include ambulatory settings, hospital settings, and also international comparisons with other countries. Let's first look at the usage of EHRs by office-based physicians. This has been measured for quite some time, and we see from the results on this figure that the level of usage has gone up substantially during the high-tech era. There are three measurements that are made for EHR usage. The top line in blue represents any EHR. That basically means that a physician has a medical or health record system that is either all or partially electronic and does more than systems solely for billing. Usage of any EHR system has reached 86% by 2015. Another measure that has been carried out over the years is basic EHR. This consists of an EHR that has a set of functions that includes things like problem lists, medication lists, clinician notes, orders, and viewing of lab and imaging results. It may not be quite meaningful use, but it represents a basic amount of functionality. More recently, it has been measured the amount of certified EHR use, and we see that that number is in the middle between basic and any. How does office-based EHR usage compare with other countries? For many years, the US was quite a laggard, although during the high-tech era, the gap has been closed. We see a number of different countries here, many of which have been at near 100% usage for many years. Countries like New Zealand, Norway, Sweden, the Netherlands, and the United Kingdom. We see the pink line representing the US and see that this roughly parallels the line seen in the previous slide, showing that the gap between the United States and other advanced countries has been closed in recent years, though we still don't have the level that some of those countries have. In hospitals, EHR adoption in the United States has been even higher, and although there are not comparative statistics like there are for office-based physicians, the US is probably a leader now when it comes to use of EHRs in hospitals. We see from the graph on this slide that the adoption of a certified EHR in hospitals has reached about 96%, so almost all hospitals in the United States. When we measure basic EHR, the numbers are not quite as high, but still reach in 2015 a level of 83.8%. Adler-Milstein determined that about 95% of U.S. hospitals achieved meaningful use stage 1 by the end of 2015, but stage 2 has been more difficult for those hospitals. Another way to measure usage of electronic health records is to look at models such as the HIMSS Analytics EMR Adoption Model, or MRAM. This is an 8-stage model that lists cumulative capabilities for EHR adoption. Starting with stage 0, there are basically no systems installed. At stage 1, there are ancillary systems such as standalone lab, radiology, pharmacy. When we get up to stage 2, there may be usage of controlled vocabularies, clinical decision support, document imaging. Stage 3 is when there begin to be things like flow sheets or structured data entry, more clinical decision support, PACS viewing outside of the radiology department. Stage 4 is when we reach significant clinical decision support, computerized provider order entry. Stage 5, closed-loop medication administration, such as with barcoding. Stage 6 is when there are structured templates for physician documentation and full use of clinical decision support. And finally, stage 7 is the transformation to, in essence, a completely electronic and paperless record. There is data continuity across the entire healthcare system. We see that currently about a third each of hospitals in the U.S. are at stage 5 and at stage 6. There are some hospitals lower than that stage, and about 6% have achieved stage 7. We've actually come quite a way. The HIMSS Analytics MRAM model has been around for over a decade. And if we look back to the numbers from 2006 and 2007, we see that most hospitals at that time were down in stages 0 through 3, and very few hospitals were above that, and none were at stage 7. Of course, usage alone is not the final answer that we want in terms of evaluating health information technology. We want to see outcomes. Do processes or outcomes of care improve when health information technology is adopted? There are many studies of this, and in fact so many that systematic reviews have been done, and an approach to performing systematic reviews has been carried out in 4 iterations now, published in different journals, with each subsequent systematic review updating the previous one. Clearly, there are benefits in many different areas of applying health information technology. And another interesting finding is that while many of the early studies were done on homegrown systems, the so-called health IT leaders, in recent years we have seen benefits accrue in settings other than those institutions that have substantial academic informatics programs. The figure on the left is from the Bunton Systematic Review, and this review looked at the outcomes of studies in various categories such as access to care, preventive care, down through things like satisfaction, effectiveness of care, and efficiency. And as is seen, a majority of the studies had positive outcomes. The more recent study by Jones and colleagues grouped the outcomes of studies by categories of meaningful use, and likewise found that there were mostly positive studies for most categories of meaningful use, with some results better than others. While numbers, whether usage or outcomes, can give us a lot of information in the evaluation of information systems, they don't always tell the whole story. Another area of evaluative research is called qualitative research. In qualitative studies, which are sometimes triangulated with other kinds of quantitative data, we seek to uncover themes, interactions, and other observations of people and or organizations. There have actually been many studies, many qualitative studies in the clinical informatics field, and there's been a whole methodology that is often attributed to Dr. Joan Ash and others that she has collaborated with. There are many results from these studies, just a sampling of some. One finding from 2003 found that there is an importance of special people who either lead to successful or unsuccessful implementation of electronic health records and other major information systems in healthcare organizations. Whether it's leaders or support people on the ground, even Luddites who can be won over to supporting the system in making sure their needs are attended to, can become very special people in the success of implementing systems. We also find that when we install information systems in complex organizations like hospitals, there are unintended consequences. There are shifts in power relationships among individuals. There are errors that occur. There are other problems that arise, and the work of Joan Ash and colleagues has identified these unintended consequences. Others have done qualitative research as well. There has been quite a bit from the various programs in the United Kingdom for implementing health IT that have yielded mixed results, some value to clinicians, but also systems making their lives more difficult in terms of delivering care and managing patients. Clearly, the results of widespread implementation of electronic health records has uncovered a number of challenges, and these are borne out in research studies that have been done, both quantitative and qualitative. Let's look at a sampling of these studies. For example, one systematic review of usability studies found that EHRs have problems with usability, effective information presentation, and lack of error prevention, minimization of cognitive load, and providing users adequate feedback. Another study looked at commercial EHR systems and found that they had deficiencies in adequate displays in graphically displaying diagnostic test results. It's also been found that vendors do not consistently apply state-of-the-art user-centered design principles that are known from other fields. In actual usage, for example, in safety net clinics, it was found that there was decreased patient satisfaction in those clinics that had implemented electronic health records, which was attributed to the clinicians paying increased attention to the computer and less to the patient. Another study was a survey of internal medicine physicians, finding that 60% of them reported time loss with use of the electronic health record, with an estimated average time loss of 48 minutes per day for attending physician and 18 minutes per day for trainees. And finally, there's this concern about the excessive amount of clicks that are required. And one study of emergency physicians found that they were spending about 43% of their time on data entry, making around 4,000 clicks in a 10-hour shift. There have also been a number of studies that have looked at the time spent with the EHR by outpatient physicians. A time motion study of 57 outpatient physicians, published by Sinsky and colleagues, found that physicians were spending about 27% of their workday with patients and 49% with the EHR and desk work. Even in the exam room, only a little bit more than half of time was direct clinical face time, and 37% was EHR and desk work. These physicians also reported, or 1/3 of these physicians reported 1 to 2 hours after work each night of additional EHR tasks. Another study looked at timestamp logs of a larger number of physicians, 471, finding that they spent about 3.1 hours on office visits and 3.2 hours on desktop medicine each day. Desktop medicine did include some interactions with patients, such as responding to emails, but over 2011 to 2014, there was a decline in visit time and an increase in this so-called desktop medicine. Now, physicians have historically spent a majority of their time in the indirect care of patients, whether it's documenting in paper charts, consulting other physicians, viewing radiology studies, and so forth. And in fact, the very first time motion study of physicians was published in 1973, well before the era of computers, and actually at that time found that physicians spent about 45% of their time in the indirect care of patients. So the larger question is, what is the appropriate amount of time spent with the computer versus with the patient? And that needs to be determined by further research. Another aspect of health information technology we may wish to evaluate is cost. That is, does health information technology reduce the cost of care, the cost to patients, etc.? This can be challenging to measure because we have different technologies, different reimbursement models, and indeed, the cost of care may be related to many different factors. There have, however, been some notable findings from studies over the years. One early study, a little over a decade ago, found that in outpatient settings, there was a positive return on investment in health information technology, in particular electronic health records, but only 11% of that return on investment went to those who made the investment, namely the practices. The others getting financial benefit were the labs, the insurers, and others. There have also been studies around health information exchange, with studies modeling health information exchange showing benefit, yet those benefits have yet to show up in real-world health information exchange. There has been another study that found lower costs from hospital implementation before and after EHR implementation. Evaluation of health information technology systems is important on several levels for those of us who are clinical informatics specialists. First of all, evaluation helps us experts determine what works best. It allows users, including organizations, to cut through the hype put forth by vendors and decide what works best. And it can help in justifying the cost and or making cost comparisons. Let's explore some more terminology and approaches to research in general. Two of the thought leaders in informatics research are Charles Friedman and Jeremy Wyatt, and they note two broad approaches to informatics research. The first of these is what they call objectivist and what most others call quantitative research, where there is some quantitative measurement of whatever the outcome variables happen to be. The most common approach in objectivist research is comparative research, where we're comparing two systems or two users, or potentially more than two. The second category is subjectivist research, which most people call qualitative research. When I think of research, I like to think of a quote from Einstein, who noted that not everything that can be counted counts, and not everything that counts can be counted. So we need both objectivist and subjectivist research. What is the general approach that we take in comparative research? Well, first we have to choose a research question. What is it that we wish to ask? And then a population to whom that research question is applied. We might be asking, for example, whether one user interface or another interface leads to fewer errors in a group of physician users. Of course, we can't do research on the entire population, so we select a sample from the population. We also have to determine the variables that we're going to measure. We look at two categories of variables. The first is the dependent or outcome variable. This is what we actually measure, and we see whether there's a difference obtained in our measurement. There are then other variables that are independent or predictor variables that explain the difference. We randomize the sample to experimental or control group, and then we obtain results that show that there is either truth in what we have found or that there has been error. Let's explore error in a little further detail. When we obtain error in research, it can be either due to bias or to chance. Bias is systematic error that's introduced by the experiment, whereas chance is random error that may occur mostly due to inadequate randomization. Bias is something we can only do by analysis and critical thinking. We have to look at the possible types of bias that can occur. There may be selection bias in that the subjects allocated to the experimental and control group are somehow different. There may be measurement bias in that the measures that we obtain on the control and experimental group may be different, may be applied differently. And then there are confounders. There may be other factors that cause differences besides just those explanatory variables that we have measured. There are other types of bias that occur in research that we should be aware of. There's assessment bias, where subjects allow their feelings toward the system to influence their performance with it. The feelings may be positive or negative. There's allocation bias. This occurs when the experimenters cheat the randomization process, and this used to commonly happen in clinical trials where clinicians would attempt to get sicker patients into the experimental group, which of course undermines the experiment. But allocation bias can occur purposefully, such as I just described, or sometimes inadvertently. There's also the Hawthorne Effect, which came to light in famous studies done in the Hawthorne factory in Chicago in the 1930s, and finding that humans try harder at tasks when they know they're being directly observed. And then finally, there's the checklist effect, where decision-making will be more complete when subjects have checklists to carry out what they've been asked to do. The other category of error is chance, and we know that sometimes we can obtain an incorrect result due to chance. This is why we use statistical analysis, which minimizes, although does not completely eliminate, chance errors. There are two types of statistical error, alpha and beta. Alpha error is when a difference represents a chance event. So something is incorrect and it happens due to chance, And the alpha error gives us the probability that an incorrect result is due to chance. And in the application of statistics, we set the p-value at 0.05 or less, which indicates a 5% or less chance of error due to chance. And this, of course, does not completely eliminate chance. There's still a 1 in 20 probability that it may occur. The other type of statistical error is beta error. In beta error, there is an actual difference when none is statistically detected. This most commonly occurs when we have too small of a sample size to have the statistical power to detect a statistically significant difference. So if the sample size is too small, there may actually be a difference between the experimental groups, but we don't detect a statistically significant difference because there's not enough statistical power. Another aspect we need to consider in research is validity. There is internal validity, where the experimental methodology internal to the experiment is sound and appropriate efforts have been made to avoid bias and chance. There's also external validity, where the results can be generalizable to the real world and have clinical significance. We may do a perfectly valid experiment with all the appropriate statistics, avoiding all the forms of bias, yet we have created an experiment that just can't be generalized to the real world, and as such, it lacks external validity. There are a number of different subjectivist approaches to research. Again, these usually go by the term qualitative research, and some of these are listed here. There is ethnography, where users are observed in their natural environment, which in healthcare is usually a healthcare setting, and there have been many important ethnographic studies and lots learned from them in informatics. Another form of subjectivist research is focus groups, where we convene individuals to have a focused discussion. There are also usability studies, where we give users tasks and watch what they do with computers. And then finally, protocol analysis, where users are asked to think aloud, to describe what they're thinking as they interact with an information system. One of the criticisms of subjectivist research or qualitative research is that it often does not produce results that are actionable, that actually give us information on how to improve the implementation of clinical information systems. One researcher in the informatics field who has been at the forefront of developing actionable qualitative research is Joan Ash, and her research team has produced a variety of tools and data collection methods that include things like site inventory profiles, so what different kinds of methods can be used at sites, and then guides to ethnography, interview questions, and rapid surveys. This approach has been successfully deployed for evaluation of clinical decision support as well as EHR safety. Dr. Ash's work has also led to the elucidation of what has been described as the unintended consequences of health information technology, the other things that happen in organizations when such technology is introduced. What additional readings might be suggested for this topic? Well, Friedman and Wyatt have both written a chapter in the new edition of the Short-Lived Informatics textbook, and they also have written a full book on this topic that was published in 2006.